Thank you, Pongpon. Today I would like to talk about the syndesmotic injury in the ankle fracture. So when everyone in this room get the case like this, so it's obvious about the injury, but it's still exciting and challenging. By the way, please keep in mind the key of treatment of the syndesmotic injury. First thing is to diagnosis, because the misdiagnosis and delayed diagnosis is very common. So when you have the injury like a PER injury, you should remind yourself about this. The radiographic evaluation, this is very common. Everyone know about this, especially the tibiofibular clear space. But by the way, sometimes you have to mention or carefully look at the medial clear space too, because the deltoid usually happen because it's caused from the rotational injury. So be careful. In case of conservative fracture or is the isolated syndesmotic injury, please watch out and be careful about the grade 2 injury, like a subtle injury, because the timing for diagnosis and surgical treatment is too long. In some literature review, about 18 months. So straight view and MRI will help you. Please use it. In case of surgery, you have many tools, intraoperative, like straight test, hook test, cotton test, and this is my lovely one, the external rotation straight test. Yes, when you found it is unstable, so the next is you have to fix it. The key is do your best to prevent the malreduction. If it's malreduction, the bad results still happen. So the key is anatomical reduction. Okay, even you found it, even you check it carefully by your fluoroscope, many literature reveal that it always have a malreduction happen. So CT scan intraoperative usually recommended. But does it matter if you like a little bit malreduction? Yes, it matter, because the long-term outcome usually bad in the malreduction syndesmotic fixation, just like a post-traumatic arthritis, even in the syndesmotic region or in the ankle joint. So how to deal with the syndesmotic malreduction? In fact, everyone always aware about this. By the way, you have to use everything you have, every facility you have, inter of CT if you have. If you can do the scope, checking it with your skill, and if you don't have CT and you cannot do the scope, use the extra radiographic criteria to help. Okay, inter of CT. Many literature, many evidence support about this. By Franke, they show that they study that in case of syndesmotic treatment, 251 patients, around 32% have a malreduction. Even the fluoroscope is still perfect. So everyone, if you can use the CT, please use it. Okay. In case of you don't have it, but you can scope. The scope help a lot, like Dr. Chilawat told you before. By the way, if you can do it, you should check another X-ray. The key is it too short or is it malrotated? The shortening of the fibula, you can use a dam side or ball side or circle side. Everyone know about this. By the way, about the rotation, in the Mortise view, please look at this picture carefully. At the distal part of the distal fibula, uh, if it's normal position, no rotation, the fossa cortex shadow, the B line, should be at around 2/3 of the distal fibula. So the line between A to B and the line between much more than the line between B to C. And the shape of the distal fibula help us to evaluate the rotation. If it is the spoon shape, it might be internal rotate, so check it. If it's a point blade shape, it might be the external rotate. Usually the external rotate. Okay. When you reduction it perfectly anatomic, so the next is screw or suture button. Screw or suture button. Okay. Many literature review about the successful of the suture button. The suture button fixation device shows similar result like a screw fixation of the syndesmosis, just like post-op and long-term follow-up radiographic results of the tibio-fibular clear space and overlap. By the way, in the suture button group, show us that it's faster to allow patient to make a full weight bearing. This is like a little bit summary for the screw and suture button. Yes, screw. It shows us the good stability both in rotational and sagittal, and it's cheaper. It's cheaper, and everyone in this room familiar with it, familiar with the screw. By the way, in the suture button, they maintain a physiological environment to promote healing of the syndesmotic ligament, and it's early weight, full weight bearing, and no screw bracket. But suture button can broken too. Please remind about this. When we look around the complication in the screw group, a little bit less than in the suture button group, but no significant. When we talk about the suture button, the new trend is we need the double suture button in divergent position. We have to reason about this to back up the device if one suture button broken or something. And it helps to prevention about the malreduction of the syndesmosis. At this time, we can say that adequate reduction is still the key. It's more important than the method of fixation. For the novel thing, the new thing, you can, if you use the suture button, to help fixation, there is the evidence to support about the suture tape technique to help augment at AITFL level. So at this time, many surgeons recommend about suture button comply with the suture taping technique at the AITFL. In case of the screw, we have novel screw too. You know that the screw not always, sometimes it can break it can broken. So they design the screw where it should be broken and it's easy to remove it. The result is look interesting. Okay, I would like to underline about the syndesmotic screw for everyone. It's not a leg screw, it's a positioning screw. The good position is just around 2 centimeters above the the tibio-talar joint, 2 centimeters, not less than this. And the second screw should be up to 1.5 to 2 centimeters. The technique for reduction and holding the cramping. You usually use the cramp at 0 degree. Angle it. If you angle it more anterior, it will increase the risk of the external rotation. So, if you are a young staff or senior staff, please ask your resident to, okay, cramp it 0 degree. And the screw, yes, everyone know that it should be a posterolateral screw, should be direct at 25 to 30 degree. And this is my lovely technique too, a prelim fixation with a KY. It helps us a lot when you fix the syndesmotic. Reduction it perfectly, prelim fixation with the KY, and then fix it with the screw or suture button. Do you want to remove the screw? It's still controversy. But by the way, in my practice, I always discuss with my patient and give them a choice. Okay, about the deltoid that Dr. Thiravuth will talk later. The key is if the deltoid is still unstable, repair it. So take home message. For syndesmotic, first thing is you have to diagnose. Beware of subtle injury, both syndesmosis and deltoid. The treatment key is anatomic reduction. Your friend, your good friend is intra-op CT. And you have to learn about the suture button and the suture tape technique. It will help you in the future. Yes. Thank you.